Good morning, guys. Today we'll be talking about what an intervertebral disc is, parts of an intervertebral disc, how the intervertebral disc changes with regards to time, age, and the process of degeneration, blood supply, nerve supply of the intervertebral disc, and also we're talking about why we give epidural steroid injections, basically the rationale behind it. All right, let's start with what an intervertebral disc is. These are nothing but hydrostatic load bearing structures, and they are present all the way from the vertebral bodies of between the vertebral bodies of C2, C3 all the way till L5 to S1. So it makes up about 25% of the total height of the spine. And we should remember an important thing is that these are completely avascular and therefore rely upon diffusion for nourishment. So it has three parts: the annulus fibrosus, the nucleus pulposus, and the vertebral end plate. Okay, so you can see the inner part it contains jelly-like substances called the nucleus pulposus. The outer part is called the annulus fibrosus, and it also has the structure label 3 here, the cartilaginous end plate, the importance of which we'll talk about later. And of course, it's attached anteriorly to the anterior longitudinal ligament and posteriorly to the posterior longitudinal ligament. So, coming to the annulus fibrosus, it is the outer structure that encases the nucleus pulposus. It is composed of type 1 collagen, water, and proteoglycans. So there's a high collagen and low proteoglycan ratio. And it is formed by 15 to 25 layers, roughly on average, of fibrocartilaginous sheaths or lamellae. And these are present with fibers running parallel to each other. So as you can see, here the fibers are running parallel to each other, and in the disc inside that, I told you it's 15 to 25 layers. So in the layer inside that, it's running at an angle of 120 degrees to the outermost layer, and the inner layer is again at 120 degrees to the its outer layer, and these run at about a 30-degree angle to the vertebral disc. So this what this arrangement does, it gives these annular fibers great strength against shearing and rotational stresses basically. The outermost layer of the annulus fibrosus is attached directly to the bone around the ring apophysis. This is the ring apophysis, the outer part of the vertebral body. That's nothing but the ring apophysis. And the inner fibers merge with the cartilaginous end plate of the disc, and is referred to as the capsular portion of the annular fibrosis. The nucleus pulposus is the central portion of the intervertebral disc. It is mainly composed of type 2. Annulus fibrosus is type 1. This is type 2. Collagen and proteoglycans. Whereas the annulus fibrosus has a high collagen and low proteoglycan ratio. This has the low collagen and high proteoglycan ratio. Why? Because aggrecan, which is the main proteoglycan present in the disc, is very important for maintaining water content in the disc and also to resist compression. So this is why proteoglycans are higher in the nucleus pulposus, so that it can hold water basically. And in a healthy young nucleus, the water content is above 80%, the total weight of the disc. So the function of the nucleus pulposus is the transmission of axial load to the vertebral below, and it acts as a intraspinal fulcrum for all trunk motion. What is this? I will explain. So the function of this function of the nucleus pulposus is highly dependent on the integrity of the annulus and the end plates. Why? Because when it is subjected to loads, the nucleus pulposus, which is originally a jelly-like substance, becomes hard and firm. And how it does this is by applying high pressure on the surrounding annulus fibrosus and the superior and inferior end plates. So the annulus fibrosus and the end plate should be firm enough to resist this pressure when the nucleus pulposus is compressed. So I'll show you with the diagram if you didn't understand. So what happens is the nucleus pulposus is in a tight enclosed space, and this is a tiny man representing the nucleus pulposus. So when it is compressed enough, the soft jelly-like nucleus pulposus becomes stone. And what I mean by stone is it becomes firm, so it can transmit the axial load from one vertebra to the next. So a jelly-like substance becomes hard, so it can transmit the load. And for it to become hard, it should not be able to escape the confines, the annulus fibrosus and the end plates. So the annulus fibrosus should be tough, and even the end plate should be tough. So axial loading turns the watery nucleus pulposus into a hard ball bearing. So not only does it become firm, but it also acts as a ball bearing upon which the lateral flexion and rotational forces of the vertebra can occur. Rotational movements, excuse me. So it acts as a pivot basically. Coming to the end plate, these are plates of cartilage that bind the disc to their respective vertebral bodies. This is the cartilaginous end plate. As you can see, it binds the disc and makes sure that the disc is in place and holds it to the respective vertebral bodies. The function of the end plate is to hold the discs in place and provide anchorage for the prevent the disc from slipping out basically. Evenly spread the applied load across the disc, and also acts, most importantly, acts as a semi-permeable interface which permits diffusion so that the disc can get nutrition. So the end plate covers the nucleus pulposus in its entirety, but peripherally fails to cover the entire extent of the annulus fibrosus. So the blood supply of the intervertebral disc, very important. So these are the interosseous arteries of the vertebral body. As you can see, they reach the end plates. The end plates have small tiny pores in them which allow the diffusion of nutrients from the outside to the inside. As you can see, only the outer portion of the annulus fibrosus receives the blood supply, whereas the inner portion of the annulus fibrosus and the nucleus pulposus is completely avascular. So it relies on diffusion for its blood supply. As you can see, the diffusion is how the nucleus pulposus and the inner portion of the annular fibrosis get its nutrition. And what happens is, when there is sclerosis of these end plates, the the arteries cannot reach the cartilaginous end plate to supply the disc, which results in disc degeneration. That's basically how it works. So as you can see here, as we age, the nucleus cells die because you can see here there's reduced vascular connections to the subchondral bone as depicted in this diagram due to the subchondral bone sclerosis. So there's less diffusion of nutrients, and so the nucleus pulposus cells are not getting nutrition, which is why they begin to die. And also they start to undergo anaerobic glycolysis, and this increases the amount of lactic acid. And lactic acid, as the acidity inside the disc increases, this results in further death of the nucleus pulposus cells. Coming to the nerve supply of the intervertebral disc, they are supplied by the sinovertebral nerve, which is a branch of the dorsal ramus. Yeah, all this is not very important. Just remember, a sinovertebral nerve supplies the posterior and posterolateral aspect. Gray rami communicans supplies the lateral aspect, and the anterior part is through sympathetic branches from the sympathetic trunk. So again, just like the blood supply, only the outer 3 mm of the annulus is capable of transmitting pain and is innervated. So inner thirds of the annulus and the entire nucleus are completely avascular and aneural. Very important point. So, and also the actual, according to studies, the actual pain centers of the disc are more heavily distributed in the posterior and posterolateral part of the annulus compared to the anterior bit. So we should remember this. This is an important point for later. So what happens is, when a load is applied from the above vertebral body onto the disc, the nucleus pulposus should transmit the load equally in all directions. But what happens is, with age, as the nucleus pulposus undergoes degeneration, you can see some areas get more load transmitted and some areas the load transmitted is less, as depicted by the small and big arrows. And eventually, when one direction receives too much load transmission compared to the other side, it eventually herniates. This is an interesting slide. This I just wanted to put up. So we can see the intradiscal pressure is lowest when we're lying supine. Is the highest when we are sitting with flexed forward with weights in our hand. Relatively high also while sitting and bending front. It's also high while standing and bending front with the load. So you can see why slouching is not good for us whether we are sitting or whether we are standing. And while sitting, if we lean back, the interdiscal pressure is the lowest. So what happens is there's a concept of nuclear migration. So when we bend forward and the spine flexes forward, the annulus fibrosis here gets compressed and the nucleus moves posteriorly. So when we extend our spine, the nucleus pulposus goes anteriorly, conversely. So we know this nucleus pulposus migration is very predictable in young individuals. However, when the disc undergoes degeneration, the pattern becomes unpredictable. As you can see here, this is a diagram showing the same thing. You can pause the video and look at it if you want. Let's talk about disc degeneration. As I said, when the end plate undergoes sclerosis, there's less diffusion of nutrients. The nucleus pulposus begins to die, and also this results in a small annular tear because even the inner portion of the annulus is supplied by diffusion itself. So the annulus starts to become weak. So when a high pressure is put from the nucleus pulposus on the annulus during weight bearing or like heavy loading, this results in a small micro tear of the annulus. And as we keep on loading repeatedly, the tear extends all the way out. So what happens is then why can't we inject new disc material? So they try to inject new disc material, but again what happens is the new disc material also will not get blood supply through diffusion, so that will also die. So that turned out not to work out. So how does this disc look on an MRI? As you can see, this is a nice bright white disc on a T2 sagittal section of the MRI, and this indicates a good water content in the disc. As you can see here, white represents the nucleus pulposus and its high water content. You can see here there's absolutely no water stored in the nucleus pulposus here, and some of the disc material has started to bulge out. This is known as disc desiccation. So cycle of disc degeneration. As the nutrient supply of the disc drops because of the less diffusion, there are few available new cells producing proteoglycan. As we told you, proteoglycan, mainly aggrecan, is responsible for holding the water content of the disc. And this decrease in aggrecan results in dehydration and decrease in hydrostatic pressure. So what is the problem with decreasing hydrostatic pressure? So hydrostatic pressure also reduces the matrix synthesis of uh, proteoglycan. So decreased hydrostatic pressure decreases intervertebral disc cell metabolism, and also conversely decrease in the proteoglycan synthesis. So this study found that the disc cells need a constant hydrostatic pressure of about 3 atmosphere to function normally. Any increase and decrease in hydrostatic pressure decreases the aggrecan production. So decreased aggrecan production further decreases the hydrostatic pressure, and this decrease in hydrostatic pressure further decreases aggrecan production. So it's a vicious cycle. So what happens is eventually the annular tear occurs, and as the annulus begins to tear from the inside to the out, once it reaches the outside, I remember I told you that the outer portion of the annulus is supplied by nerve endings. So this becomes painful. So once the annular tear extends completely all the way out, the patient starts to experience the pain of an annular tear. Now, three types of annular tear: rim tear, concentric tear, and radial tear. I'll go over the exact different tears in another video, but this is just for completion's sake. So, under ideal situations, the biomechanics of motion are such that the nucleus pulposus will bear 80% of the weight transmitted down, and 20% will be through the facet joints. But as the ability of the annulus to contain the pressurized nucleus pulposus decreases, there results in disc herniation, and we tend to load more posteriorly to the facet joint. So it becomes 60 nucleus and 40 facet joints. It's just an example. So what happens when the annular tear extends all the way from the inside to the outside? So as the nucleus pulposus undergoes degeneration, it produces cytokines. Cytokines such as TNF alpha, phospholipase A2 are spawned from the degenerated disc itself, and through the passageway of the annular tear, they come in contact with the nociceptive pain producing fibers at the outer aspect of the annulus, and this results in a painful inflammatory process. Also, due to uneven loading of the disc, what happens is we tend to load the posterior annulus fibrosus more. And I told you previously that the posterior and posterolateral areas of the disc are where more nerve endings are present. So this results in a mechanical compression. There's chemical irritation of the nerve endings from the cytokines. There's mechanical irritation of the nerve endings from direct pressure, and also the herniated disc material also presses on the nerve roots. So all these three things combine and cause back pain. So why do we give an epidural steroid injection? Epidural steroid injections usually benefit patients when the nature of back and leg pain is acute in nature, less than 3 months. They usually respond better. However, patients who do not respond to epidural steroid injections once and who had radicular pain for at least 12 months usually benefit more from surgery. So when we give a corticosteroid, we block the arachidonic acid pathway. So we block the phospholipase A2 enzyme and the cyclooxygenase pathway. So prostacyclin, prostaglandin, thromboxane, and leukotrienes are not released by the nucleus pulposus, which are released by the nucleus pulposus, do not reach the nerve endings but are neutralized by the corticosteroids. So these cytokines are not able to act on the nerve endings and produce sensation of pain and inflammation because they are being blocked by the corticosteroids, which we give in an epidural steroid injection. And this is how epidural steroid injections cause pain relief. And there's two types, transforaminal and interlaminar. And it's shown, research has shown a good, well-placed transforaminal injection is better than an interlaminar ESI in terms of short-term pain improvement and fewer long-term operative interventions. All right. I hope you learned something from this video today. Thank you.